Good evening, everyone. Welcome you all for the IPNA endorsed Webmaster Series 2022, which is completely on Pediatric Tubular Disease Symposium. And today we have the polling session open for you. And we have two eminent speakers, Dr. Susan Uthup and Dr. Mehul Shah, who's going to talk on diabetes insipidus and magnesium disorders. And we have our moderator, Dr. VVR Satya Prasad. He is actually completed his IPNA fellowship from prestigious All India Institute of Medical Sciences, New Delhi. He is a lead consultant at Rainbow Children's Hospital, Hyderabad, and his interest is towards renal vasculitis and intensive care. He has got a lot of awards and honors to his CV. Over to Dr. VVR Satya Prasad to actually introduce the speakers.
Thank you. Thank you, Doctor. So it gave me immense pleasure to introduce Dr. Susan Uthup. She is one of the senior most pediatric nephrologists. She is head and the professor of Government Medical College. Her special area of interest is pediatric CKD and dialysis. She is a first ranker in first year, second year, and third year MBBS, and final year MBBS. She's our best outgoing student from Kottayam Medical College in 1991. And she has done fellowship in International Society of Nephrology in 2012 and pediatric nephrology fellowship from Cincinnati Children's Hospital Medical Center, USA in 2012. So over to Madam.
Thank you, Dr. Satya Prasad.
Now the topic is about diabetes insipidus, gas-based cereals. First we'll go through this, then later on magnesium metabolism by Dr. Mehul.
Thank you, Dr. Satya Prasad, for those nice introduction. And I thank Dr. Kalevani and her team at Mehta's Hospital. And my pranam to the guru of pediatric nephrology, Professor Nammalwar. And today, I am going to talk on a little difficult and intriguing problem that is actually diabetes insipidus in children. And so we all know that diabetes is a situation when you have a lot of the components in the blood, but it is not available to the cells. So similar to diabetes insipidus, where sugar is everywhere, here in diabetes insipidus, there is water everywhere, but water is not there, and the cells will be shrinking, and the sodium will be going up, and the child will be very thirsty, and so a little bit difficult problem for the child. So in the next 30 to 40 minutes, I will be talking on stories of thirsty children and how the diabetes insipidus physiology is happening at the cellular level. What are the manifestations? How will we evaluate? And we will also touch upon a little bit on the management, recent advances that has come up, and finally conclude the session. As I have already told you, water is essential for life. And in water, only the life originated. Adaptation to terrestrial life required the acquisition of water-saving mechanisms. Movement of water into and out of the cells is a fundamental biological process that is essential for life. And this water movement is actually regulating the activity of individual cells, and it is responsible for the functioning of various organ systems and thus the whole body water balance. And the kidneys, the wonderful organ, is maintaining the fluid and electrolyte balance by adjusting the urine volume and composition according to our physiological needs. Kidneys are filtering almost 180 liters a day, but out of that, only 1 to 2 liters of urine is going out of the body. Depending on the osmolality of the body fluids, in an overabundant water supply, the urine concentration can be as low as 100 milliosmoles per kg, and kidney can even make it more dilute to 50. And 1,200, that much concentration is possible in severely restricted water supply. So let us see the story of a 4-year-old girl who was drinking almost 8 to 9 liters of water daily. The symptoms were gradually onset. She used to wake up at night 5 to 6 times to drink water. The frequency and volume of urine increased 10 to 15 times during the day and 5 to 6 times at night. So the child was actually going on drinking, and not having time to really eat well. And so the child used to vomit a lot also because of this lot of water that is being taken. When she came to the hospital on examination, she was febrile. She was alert and not dehydrated. And she was actually a 4-year-old girl with weight 13 kg and height 84 centimeters. There is obvious growth failure that was there. Blood pressure was 80/50. So why this child is so thirsty? So going on to the investigation, it was seen that the urine was almost like water and specific gravity was 1.000. The urine microscopy was normal. There was no sugar or protein in urine. And her blood urea creat normal, sugar was normal. But look at her sodium. It was borderline elevated. It was 144. The bicarbs and potassium were normal. The calculated serum osmolality was 299 milliosmoles per liter. And at the same time, urine was very dilute. An abdominal sonography showed hydronephrosis, which was bilaterally there and but mild. And there was ureters were normal and there were no cysts or calculi in the kidney. So with a high serum osmolality and a very dilute urine, a possibility of diabetes insipidus was considered. And so now the problem is whether it is central DI or nephrogenic DI. So if the serum osmolality is more than 300 and concomitant serum or urine osmolality is less than 300, it is actually indicative of DI. If the urine osmolality is more than 600 with a serum osmolality of more than 300, you're unlikely to be dealing with DI. If the urine osmolality is intermediate and a clinical suspicion of DI remains, we have to go ahead and do a water deprivation test in a child who is stable like this 4-year-old girl. Special caution has to be taken in infants. It is dangerous in neonates to have water deprivation, and in a dehydrated state, also water deprivation is not to be done. And so the water deprivation test is to be done in a closely monitored inpatient setting, and we have to have an IV line established before you start the test. And we have to stop the test at any time the patient exhibits signs and symptoms of hypovolemia. If more than 5% dehydration is there, don't go ahead with the test. And so you will be having a baseline weight and vital signs taken. You will be doing a baseline sodium, serum osmolality, urine osmolality and urinary sodium, and you will be recording the urine output, and you will be doing it every hour. And at some point, if the serum osmolality is actually going up, and it is almost, and urine osmolality is also going up, and it is more than 600, and then you have to stop the test, and the child is not having DI. But if the serum osmolality is going up and the urine osmolality is remaining below 600, the child may be having DI, and so you are going to give the vasopressin. And after giving vasopressin, 30 minutes and 60 minutes after subcutaneous vasopressin, you will be checking the urine osmolality and serum osmolality. So the index child, actually before water deprivation, the urine specific gravity was very low, serum was 299, and her urine volume was 12 ml per kg per hour. After water deprivation, you can see that there is not much of change, and the urine volume is still 11 ml per kg per hour. But once you gave desmopressin, you could see that her urine output dropped and the urine osmolality also went up. So this child is possibly having a central DI because the urine osmolality improved with vasopressin. So a complete nephrogenic DI is urine osmolality remains below 300 and there is no increase of more than 50% after desmopressin injection. If the urine osmolality improves to more than 50% after DI desmopressin injection, it is central DI. And so the problem is with partial central DI and primary polydipsia, where the things are intermediate. And if the increase is more than 9%, you take it as partial central DI, and the improvement in urine osmolality is less than 9% after desmopressin, you can take it as primary polydipsia. In normal individuals in DD APP, the urine osmolality should go up to more than 800. So let us go to the second child, a 2-year-old boy with a brain tumor. He was admitted with seizures and a brain MRI showed large suprasellar tumor. And histopathology confirmed a low-grade diffuse glioma with hydrocephalus, a VP shunt and suprasellar lesion debulking was done. After surgery came the problems. He developed polyuria and hypernatremia, which was managed with intravenous vasopressin. After 2 days, the sodium levels were remaining at borderline while on treatment, and the urinary sodium started increasing, and polyuria was continuing. Over the next 10 days, he developed hyponatremia and the vasopressin was stopped, but still the hyponatremia persisted. Then after 2 weeks, it was again the sodium was going up, but the polyuria was still there and sodium started going up. So this diabetes insipidus is a polyuria polydipsia syndrome. And in the central DI, there is distraction of the neurohypophyseal neurons, or there could be a mutation in the arginine vasopressin. And so, whereas primary polydipsia, actually there is an excessive fluid intake, and it can be a dipsogenic polydipsia, or it can be a compulsive water drinking. And then this renal resistance to serum AVP is the problem in nephrogenic DI. The decreased response to AVP can be due to mutations in the AVP receptor 2 or aquaporin channels. So the renal tubule is actually the nature's wonder. The physiology of urinary concentration is very interesting. The bulk transport is happening at the proximal tubule, which is having the constitutive expression of aquaporin 1, as well as the solute reabsorption, which facilitate the passive reabsorption along the osmotic gradient. And the loop of Henle is there, the countercurrent, the concentrating and diluting techniques that is there, and the urinary concentration is happening. And at the end of the loop of Henle, you can see that it enters with around 300 and the urine is coming out again. The ultrafiltrate that is coming, tubular fluid that is coming out of the loop is again 300. So how is the subsequent concentration of urine happening? There comes the collecting duct, which is the point of interest for today's talk. At entry into the AVP sensitive connecting tubules and collecting duct, the urine osmolality is at that point only 50 to 100. And the final osmolality of urine depends solely on the water channel availability there. If these channels are present, water will exit the tubule following the interstitial concentration gradient, and the urine becomes concentrated. But water channels will have to be present. If no water channel is present, this cortical collecting duct segment is impermeable to water, and a dilute urine will be excreted. And who is the controlling and who is the key regulator? That is the vasopressin secreted by the hypothalamic neurons in response to changes in soma volume. That is the key regulator for water permeability of the collecting duct. So let us have a little bit of look at the story of water channels. So it had long been suspected that water movement across the biological cell membranes was in some way enhanced or facilitated by these pores or channels. But the search to identify these channels was long and tedious, and people were actually not finding it. And this man's group came, that this is Peter Agre. The Agre group, while looking at the rhesus factor protein in red cell membrane, noticed a consistent contaminating band on their gels at around 28 kilodalton. So what they did was he felt that this could be the intriguing water channel that may be there. And so he started experimenting on the Xenopus oocyte membrane. The Xenopus oocyte membrane is normally very impermeable to water. And it is the nature's way to help protect these eggs. Once they are deposited into fresh water, they would burst open if the membrane was permeable. So what he did was his group injected mRNA coding for the putative water channel into this oocyte membrane, and such oocytes were dropped into distilled water and did exactly that. They did burst, and the control oocytes remain intact. So this was called TIP28 initially, and later named as aquaporin water channels. And so water balance is actually in the body regulated. Let us look at what is happening in the brain. Vasopressin is the key regulator of water balance, and the regulation of vasopressin secretion is happening with lot of control mechanisms that are there in the hypothalamus and the pituitary. The sensory neurons that are located in the subfornical organ, median peptic nucleus, and organum vasculosum of lamina terminalis, they are continuously monitoring the concentration of various ions in the blood. The neurons will be tracking the osmotic conditions and signal any perturbations to the magnocellular neurosecretory cells in the supraoptic nuclei and paraventricular nuclei. And these magnocellular neurosecretory cells then go on to produce and release vasopressin into the circulation through the posterior pituitary. And who is regulating the vasopressin secretion? The changes in the osmolality is actually regulating the vasopressin secretion. So the changes in osmolality will cause an inversely proportional change in the cell volume. So you can see that the set point is in the middle, and the hypertonic and hypotonic the points are there. And when the osmolality is actually increasing, the cells will shrink. And the shrinkage of these cells will increase the activity of the transient receptor potential TRPV1 channels, and the depolarization will increase the action potential firing rate, and the vasopressin is released from the axon terminals in the neurohypophysis. And increased vasopressin levels in the blood will enhance the water reabsorption by the kidney, and then this restore the extracellular fluid osmolality towards the set point. Whereas if the hypotonicity is happening, the cell volume will increase, and that will produce a hyperpolarization and inhibition of firing of the TRP channels, reduces the vasopressin release and promotes diuresis. So this is what is happening in the brain. And now let us look at what is happening in the cortical collecting duct in the kidney. And so the AVP which is coming into the blood, that will bind to the G protein coupled AVP2 receptor at the basolateral membrane of the cortical collecting duct, the principal cells of the cortical collecting duct. And this will result in increased production of cyclic AMP by adenylate cyclase activation, and which in turn will increase the activity of the protein kinase A, which will induce the phosphorylation of the target protein aquaporin 2. And no, that is the aquaporin 2 is actually that this exocytic insertion is happening because that is mediated by the pKa, and this will result in these channels which are actually inserted to the membrane by exocytosis that will increase the water reabsorption. At the same time, the long-term regulation is also mediated through this protein kinase A, that is a transcription of aquaporin 2, and more aquaporin 2 is synthesized. But we have to understand that there is a constant movement that is happening here, that is the exocytic insertion and the endocytic retrieval which is happening, and the aquaporin 2 channels are actually stored in the intracellular vesicles inside the cell. So this is what we have already discussed. So you can see that this endocytic vesicle which is there, and once this mechanism is happening, it is actually getting inserted, and the exocytic insertion and the endocytic retrieval that is continuously going on in the cell. And the aquaporin 3 and 4 water channels which are present on the basolateral side of the membrane will help in the reabsorption of water that has entered into the cell to the interstitium. So all these aquaporin channels are important in the cortical collecting duct. So now let us look at the etiology of central DI as well as nephrogenic DI. Central DI, as already we have said, there is deficiency of AVP synthesis or secretion. It can be acquired due to tumors, meningitis, encephalitis, then histiocytosis, hemochromatosis, which are actually histiocytosis is Langerhans cell histiocytosis we do come across in children. And then various drugs, trauma and surgery as the child whom we have already presented, and then hypoxic encephalopathy, the brain trauma, and at the same time the idiopathic variety is also the 20-25%, the reason for which is yet to be revealed. And the congenital is actually less common, which can be a familial autosomal dominant and the familial autosomal recessive DI, then that wolframin gene defect that will lead to diabetes mellitus, diabetes insipidus, optic atrophy, deafness, and of late it is actually MOAUD, that is the urological abnormalities are also there, and these children will be having some bladder dysfunction also. So that is again another cause, but central DI that is occurring in this Dittmore syndrome is actually, Dittmore syndrome is actually not very severe like the other varieties. Then congenital anatomic defects like septoptic dysplasia, holoprosencephaly, and the list is long, can also lead to vasopressin not coming and central DI. So let us look at the triphasic response that happened in the child after surgery. So this response has been mentioned after the pituitary stalk damage. The damage can be a low stalk resection or a high stalk resection. A transection at the low levels, that is at the diaphragma sellae, will result in only transient central DI, which may improve, whereas a high stalk transection at the level of the infundibulum can produce a permanent DI. And so there are three phases of response that are going to be there. That is, in the first phase, actually, it is actually an axonal shock phase when that connection that is severed result in the release of, which prevents the stimulated release of AVP, and that is the phase when the diabetes insipidus will set in. And in the second phase, actually, there is a lot of release, uncontrolled release because of the axon terminal degeneration that is happening, and that results in a syndrome of SI88. And at the same time, we also have to understand that in situations of brain injury, there can be a component of cerebral salt wasting, which may also come up. So these things may complicate the situation. And the third phase, after all the stored AVP in the posterior pituitary gland is released and the cell body's destruction is more than 80 to 90%, there will be a retrograde degeneration. And at that time, a permanent DI situation will be sitting. And similar type of destruction and disease can happen in autoimmune and inflammatory disorders, as well as rapidly enlarging anterior pituitary lesions, which may compress the release of this vasopressin from the axon terminals. So let us look at another child, a 1-year-old male baby who presented with thirst, irritability, and seizures. He had craving for water, and the increased urinary frequency has been noticed from 6 months of age. When the baby started crawling, the mother noticed that the child used to drink his own urine, and he was not gaining weight. He was always thirsty and irritable and used to drink a lot and vomit a lot. And on evaluation, this baby was febrile and irritable, and his body weight and height were actually not picking up, and his system examination were non-contributory. What is the problem with this infant? Going on to investigation, the colorless urine, which was looking like almost water with a very low specific gravity, the urine microscopy, protein, sugar, everything is normal. The RFT is normal. And actually you can see that the creatinine urea are actually very low in these people because of the lot of urine that is being passed. The sodium in this baby was 149 and the bicarbs and potassium normal. The serum osmolality is 310 and the urine is very dilute. Sonography was essentially normal. So again, diabetes insipidus, whether central DI or nephrogenic DI, all of us know that we now will be going on with the MRI brain, and that was normal. Then, and so water deprivation is not to be done in this baby because the baby is already having a serum osmolality that is more than 300 and the baby is not stable. And also in infants, we don't usually go ahead and do water deprivation. So a genetic study was done which showed an AVP receptor 2 mutation, which is an X-linked recessive, likely pathogenic. And so that baby was having a nephrogenic DI, and nephrogenic DI can be congenital or acquired. And in the pediatric age group, we will be seeing more of congenital problems, and it can be due to a mutation of the this AVP receptors. X-linked variety is this XQ28 gene mutation, which is encoding the gene that is encoding the AVP2 receptor. The autosomal recessive variety is there, which is coding for the aquaporin 2, which is on chromosome 12, and there is an autosomal dominant variety also. So the X-linked one is seen in almost 90%, autosomal recessive in 9%, and autosomal dominant NDI in only 1% of cases. So you can see that the abnormality that is there is actually shown. The congenital nephrogenic, there is a mutated V2 receptor, so the AVP is not able to act. And also you can see that the lithium toxicity, which is very common, the drug induced, which will be actually acting at the adenylate cyclase activation. So various steps. So once this AVP is coming to the principal cortical collecting duct, principal cells of the cortical collecting duct, you know that once the AVP receptor is coming, the V2 receptor is there. The V2 receptor has to recognize AVP, and then subsequently the downstream, so many steps are there. Each step is important, and each step can be affected, which can be affected with various drugs or genetic disorders. So this, considering the clinical presentation, the age at presentation in both central and nephrogenic DI, if you look at, you can see that in nephrogenic DI, there can be a history of antenatal hydramnios. Baby may be presenting in the neonatal age group itself, and early infancy, usually they will be coming out with the symptoms. Whereas in central DI, it can present in infancy or between 5 to 6 years. Rarely they may be presenting in the adulthood. And that is about the genetic disorders. You know that other acquired conditions can be presenting at any age, depending on when and what is the problem. Then this etiology and mode of inheritance, genetic, or the background, all that we have discussed. The clinical presentation in central DI, they are thirsty and there will be growth failure. Whereas in nephrogenic DI, the child will be severely thirsty, there will be failure to thrive, and mental retardation secondary to hypernatremic seizures is common in nephrogenic DI. The basal urine osmolality is low in both, and post water deprivation also, both of them will be low, whereas post AVP, this vasopressin, then this central DI will respond, whereas the response is poor in nephrogenic DI. And MRI also may help us like in that the initial, the tumor child who is having a problem, then this long-term prognosis for central DI is good because we can give the AVP and the kidney level, the principal cells, mechanisms are all normal. So they respond very well and the outcome is good. But if it is a brain tumor and all, you know, the acquired conditions, depending on the etiology, the prognosis may vary. Whereas nephrogenic DI, all of us know who have treated children with nephrogenic DI that it is a real difficult situation. You will be using multiple drugs to enhance the response to vasopressin at the level of the kidney, and so many drugs are used, combinations are used. So nephrogenic DI can occur with hypokalemia, hypercalcemia, hypercalciuria, and also with lithium. And in hypercalciuria, there is activation of the calcium sensing receptor, which will increase the intracellular calcium levels and thus will enhance the basal autophagy, which will actually result in the cargo being taken up for degradation, and the cargo which is containing this aquaporin channels and the urate transporter A1, they are not actually released at the sites where they have to act. So that is the problem in hypocalcemia, hypercalcemia, hypercalciuria, and hypokalemia. Whereas in lithium toxicity, what happens is lithium will be inhibiting the glycogen synthase kinase 3 beta, thus will be acting through the adenylate cyclase activation mechanisms are actually hampered and aquaporin 2 expression is reduced. So this we have already discussed. It is 90% is X-linked recessive and 9% is autosomal recessive and 1% is autosomal dominant. And so how will we evaluate? So a careful history is important. The drugs and toxin exposure, family history of similar things, visual symptoms are very important, as well as a visual field examination in a bigger child may help us to find out whether there are some neoplasms or pituitary hypophysitis and things like that. Then lab test will be, of course, including the blood chemistry and calculating the osmolality, urine osmolality. And then you can also, in certain disorders like the tumors and vasculitis and sarcoidosis, and also all the specific tests which are there, that is all depending on, you will be planning these based on the clinical situation, examination, and then subsequent evaluation is to be planned. Pituitary MRI will help, as well as the other, the consultations and things like that is depending on what is the clinical picture. But the baseline evaluation we should be knowing, and that will usually help us to coin down on the diagnosis of diabetes insipidus. The radiology is important in diabetes insipidus. They enhance this gadolinium enhanced MRI of the, and looking at the cellular and supracellular regions will help us to assess for adenomas, empty cellular, infiltrative disorders. The pituitary bright spot is there. That is an area of hyperintensity, and this results from T1 shortening effects of stored AVP in the neurosecretory granules in posterior pituitary. And pituitary stalk is to be assessed. Diameter more than 2 to 3 millimeter is considered as pathological. So how will we approach? Suspected hypotonic polyuria, you have to confirm the polyuria. That is the first step. You have to see whether there is real polyuria, that is more than 4 ml per kg per hour in the child and more than 6 ml per kg in an infant. And the urine osmolality is to be assessed. If it is less than 800, then you have to look at the serum sodium. If the serum sodium is very low, that is less than 135, it's actually lower than the usual, then primary polydipsia is to be considered. But if it is between, if it is more than 147, it is high serum sodium, it can be a central or nephrogenic DI. The normal serum sodium is the situation when you will be a little more confused, and always remember that these children may drink a lot of water to maintain their serum sodium between 136 and 146, and they remain okay. And here we will be going ahead with the water deprivation test, which is an indirect assessment of the desmopressin activity, vasopressin activity at the level of at the brain level as well as at the level of the kidneys. And so we have already seen that if there is a more than 50% increase following desmopressin, that is complete central DI in a patient whose serum or urine osmolality is not improving with water deprivation. And if the improvement is less than 50%, it is nephrogenic DI. And then we have already discussed about the 9% thing, which will be looking at and looking for partial central DI and primary polydipsia. So baseline copeptin level is actually a direct assessment of the vasopressin, how it is acting. And so the copeptin is actually the C-terminal segment of the AVP prohormone, and it is an actually AVP surrogate. And it has become a promising biomarker for the differential diagnosis of polyuria polydipsia syndrome. So copeptin levels, which is more than 21.4, is indicative of a complete or partial nephrogenic DI. Whereas if it is less than 21.4, we will be giving 3% saline, that is the hypertonic saline test. The stimulated copeptin levels more than 4.9 and the plasma sodium more than 150 is indicative of primary polydipsia. But if it is remaining low, less than 4.9, when the plasma sodium is more than 150, it is complete or partial central DI. So the final part of my talk is management of diabetes insipidus, how we will be doing it. Our therapeutic goal is actually not curing the situation, because most often the curing is not possible. So we will be aiming at reducing the polyuria and decreasing the thirst so that the child is able to grow adequately and maintain a normal lifestyle. We have to provide free access to water, never restrict water. If the child develops a diarrheal illness or something, you have to be very, very careful. You have to give water. You may have to resort to IV fluid therapy. So don't try to manage a child with DI or for that any renal disorder with ORS and trying to help them. Dietary management will help to optimize free water excretion by reducing the protein in the diet. The calorie to solute ratio can be organize and improve. And therapy with vasopressin analog desmopressin is really helpful in central DI. And therapy with drugs to enhance the water reabsorption is what you do in nephrogenic DI and the treatment of the underlying cause. So treating the underlying cause, free access to water and diet, provide a high calorie solute ratio in the diet, and then thiazide diuretics. Hydrochlorothiazide is the most useful therapy, which will enhance the sodium excretion at the expense of water. And then prostaglandin synthesis inhibitors like indomethacin will enhance the PCT water absorption, as well as a reduction in GFR that is happening because of this, and that improves. And the epithelial sodium channel blocker amiloride in combination with thiazide diuretic was used, but amiloride is off late, not available for clinical use in our setup. And high dose DDAVP along with indomethacin is useful in B2 receptor mutations. So what is happening around across the world, because this disease, nephrogenic DI, is difficult to treat. So the improved understanding of specific molecular defects have led to targeted rational treatment, but the progress is actually slow. Focus is actually on the restoration of AVP signaling upstream of aquaporin 2. We know that once AVP is there, it cannot act because the series of steps that are happening following AVP reaching the principal cell of the collecting duct is the problem. In aquaporin 2 mutations, this sort of therapy in the upstream of aquaporin 2 modulation is not very effective. In such cases, the novel approach must be gene therapy for patients with such mutations. The AVP2 receptor antagonist, that is in genetic NDI with missense mutations in the AVP2 receptors that lead to misfolding and retention in ER and degeneration. Endoplasmic reticulum associated degradation of AVP is happening because of AVP misfolding. And so these molecular chaperones, which help to induce proper folding, can be tried, and which will actually have the mutant receptor escape the ER, traffic to the cell membrane, and provide normal signaling. So cell-permeable AVP2 receptor antagonists are molecular chaperones that fit into the AVP binding pocket and induce proper folding of the receptor so that they will promote the surface expression of the receptor and less likely to diffuse off the receptor and thus enable normal AVP signaling. And one molecule that is being tried, and these are all actually experimental, and clinically we are not yet getting these molecules for use. And another is the EP2 receptor agonist butaprost, which is actually in rat model is helpful. So potential non-vasopressin treatment of NDI, the lot of drugs which are actually clinically in use have been tried, which will actually act at the levels where the downstream of the B2 receptor level that is acting at the adenylate cyclase. An indirect way of looking at activating the adenylate cyclase, not through the cyclic GMP and cyclic AMP activation. Those are the proteins like P2, Y12, EP4 and all, and such molecules. So clopidogrel will be acting through this receptor, resulting in the increased adenylate cyclase activity. And the metformin will stimulate the adenylate, adenosine monophosphate phosphorylase kinase that will help in the phosphorylation of SYN and thus activate the aquaporin 2 as well as the urea transporter 1. Then simvastatin, sildenafil, erlotinib, these are all molecules which will actually through cyclic GMP stimulate the insertion of aquaporin 2 to the apical plasma membrane. So these molecules are actually being tried in experiments. They are already clinically useful in other situations. So whether they will be helpful for diabetes insipidus is our question now. And in the pipeline, there are AVP2 receptor agonists which are there. Vasopressin analogs are being tried. Prostaglandin receptor agonists, secretin receptor agonists, cyclic GMP phosphodiesterase inhibitors, and in the Brattleboro rats, the model of central diabetes insipidus, where deficient vasopressin production by hypothalamus is there. The cyclic GMP phosphodiesterase inhibitors have been tried, and there was a short-lived increase. And so a lot of molecules are being tried, and because nephrogenic DI is an intriguing problem, and the child is requiring a lot of drugs at the same time, the not very good in the clinical outcome. So genome therapy, genome editing of somatic tissues or embryos to correct the mutant genes is called embryo editing. And that is the gene therapy, the kidney specific delivery of wild type ADP2 receptor aquaporin 2 could cure the congenital nephrogenic DI. So our understanding of molecular physiology of urine concentration has advanced tremendously in the past 25 years. The nephrogenic DI is more common than central DI. Water deprivation test is useful in the correct situations. Desmopressin is the drug of choice for central DI. This nephrogenic DI, we have to focus at present. Currently, we are focusing on dietary modification, thiazides and inhibitors of prostaglandin synthesis. Our treatment aim is to approach this to ameliorate the clinical phenotype, and the novel therapies are in pipeline, and gene therapy may provide a complete cure for nephrogenic DI in future. Thank you.
That is in detail and excellent talk, madam. Very much in detail, exhaustive. Thank you. A few questions, madam. This is about duration of medication in central DI. What is the duration of medication? If child is showing response, and what is the maximum dose?
Prasad, sir, sorry to intervene. Like, can we take the questions towards the end of the session?
Yeah, sure. Yeah.
Can you introduce the next speaker, sir?
Yeah.
Satya Prasad, sir, can you introduce the speaker?
Yeah. It gives me immense pleasure to introduce Dr. Mehul, sir. He's my teacher and guide. I worked under him in 2004 and 2005 as a registrar, and got inclined towards pediatric nephrology. Sir has several publications in national and international journals, and he has written chapters in textbook. Presently, he is a senior consultant pediatric nephrologist in Apollo Hospital and Little Star Hospital in Hyderabad. Over to sir.
Just 1 second.
And his talk will be on magnesium metabolism today.
Yeah, 1 second. Dr. Namalwar Garu, Kalaivaini, and friends. Hello, am I audible?
Yes, sir, you're audible, sir.
At the outset, and Satya Prasad, thank you so much for the kind invitation. I think after the excellent talk by Susan, we'll move forward to discussion on disorders of magnesium, which I feel are often neglected and underreported in our clinical practice. As we all know, magnesium is the 4th common abundant cation in the body after sodium, potassium, calcium, and it's the 2nd most abundant intracellular cation. Most of it is located inside the nucleus, mitochondria.
Mehul,
Hello?
Are you sharing your screen, sir? You're not able to
Yes.
see your PowerPoints.
I did. Okay, 1 second. Let me... Is it okay?
Can you put it in full screen, sir?
Yeah. 1 second.
Right.
Is it okay?
Yeah, perfect, sir.
Okay. So majority of the intracellular magnesium is bound to ATP. And as we know that magnesium is an important cofactor for many enzymes, including ATP generating reactions. Physiologically, magnesium plays an essential role in bone formation, neuromuscular stability, muscle contraction, insulin mechanisms, as well as cardiac excitability. Through its role in ATP generation, magnesium plays key roles in muscle contraction, relaxation, cell membrane stabilization, heart rhythm, as well as vascular tone. 1 second. I'm just not... therefore, the tight regulation of plasma magnesium level is of vital importance. As we know, the total body magnesium stores are about 2000 milliequivalents, which is approximately 24,000 milligrams or 24 grams, of which predominantly 99% is intracellular and only 1% is in the extracellular compartment of the body fluids. Of this, majority of the magnesium stores are in the bones, followed by muscles, and some other tissues, including the heart, the liver, and the kidneys. Of the 1% in the extracellular fluid, about a third is in the plasma and 70% is in the RBCs. The circulating magnesium in the plasma is in the ionized or free form, that is 70%, about 25% is bound to albumin, and 5% is complex to anions such as phosphates, sulfates, and oxalates. As we all know, the physiological reference range for plasma magnesium concentration is 1.8 to 2.4 milligrams per deciliter. Since plasma magnesium is only about 0.3% of total body stores, we should be aware that measurement of plasma magnesium will not accurately define the body stores of magnesium. By the time we see a decreased magnesium level in the plasma, the body stores of magnesium are already depleted. So moving on to magnesium homeostasis, the daily recommended allowance of magnesium in an adult is about 360 milligrams, slightly higher in women as compared to in men. Of this, about 30% in a healthy individual is absorbed in the intestines. 20 milligrams is secreted in the various gastric as well as intestinal juices. And hence there is a daily fecal output of about 260 milligrams. So the net daily uptake of magnesium is around 100 milligrams, which once it enters the blood compartment, most of it is distributed into the organs like bones, muscles, and heart, liver, and kidney. And to keep the plasma magnesium in balance, the kidneys would excrete the amount which has been absorbed through the gastrointestinal tract. So the daily urinary output usually matches the daily net uptake depending upon the requirement of the body. In children, approximately 3 to 4 milligrams per kilogram of body weight is the recommended dietary allowance of magnesium, and it depends upon the age, with 30 milligrams per day in an infant less than 1 year to about 240 milligrams per day in an adolescent. As we all know, the foods which are rich in magnesium are nuts, beans, whole grain cereals, dark green leafy vegetables, dark chocolates, as well as soya. What happens when magnesium is consumed in the diet? About 80 to 90% of the magnesium which is absorbed in the intestine is absorbed through the paracellular pathway, and that's a passive movement. It's a non-saturable mechanism of absorption. Most of this takes place in the distal jejunum, ileum, and also the colon. However, about 10 to 20% of magnesium is absorbed transcellularly through magnesium channels, which are denoted over here as TRPM6 and 7, which is transient receptor potential melastatin 6 and 7. These are the two active transporters which will move magnesium from the lumen into the cell. The paracellular movement of magnesium occurs through tight junctions, mainly the claudins. Once inside the cell, the exit of magnesium, which wasn't so obvious and understood until recently, is now thought to be due to this transporter called as CNNM4, which is one of the old conserved vertebrate metal transporter, which will transport the magnesium from inside the cell to the interstitial and the blood compartment. The other way magnesium is released into the circulation is believed to be due to a sodium magnesium antiporter, where magnesium enters inside the cell and sodium enters inside the cell and magnesium is released into the circulation. Moving on to the renal magnesium handling, unlike the other cations, especially the sodium, magnesium is not reabsorbed predominantly in the proximal tubule. About 70 to 80% of plasma magnesium is ultrafiltrable because that's the free amount of magnesium in the plasma. Remaining is bound to albumin and other anions, and hence it is not going to be filtered. So the free magnesium is going to be filtered. Once it enters the tubular lumen, about 20 to 25% is reabsorbed across the proximal tubule, depending upon the reabsorption of sodium chloride and water, which would then increase the luminal fluid magnesium concentration and then aid in the passive reabsorption of magnesium in the proximal tubule. Through micropuncture studies, it has been now documented that predominantly 60 to 70% of magnesium is reabsorbed in the thick ascending limb of loop of Henle through the paracellular route, assisted by the claudin 16 and claudin 19 proteins. 5 to 10% of magnesium is reabsorbed in the distal convoluted tubule, and this is the site of active reabsorption of magnesium, and this is the site where fine-tuning of magnesium absorption takes place. Negligible amount of magnesium is reabsorbed in the cortical collecting duct, and about 1 to 3% of the filtered magnesium is excreted into the urine. So in physiology, about 1 to 3% is excreted. When there is magnesium deficiency, the kidneys have the capacity to reabsorb 99.5% of magnesium, and the urinary excretion can drop to less than 1%. This is another schematic diagram of reabsorption of magnesium along the various segments of the nephron. I would like to highlight over here the reabsorption of magnesium in the thick ascending limb of loop of Henle, which is on the right side. And as we know, the reabsorption of sodium chloride and potassium through the electroneutral NKCC2 transporter on the luminal membrane of the thick ascending limb of loop of Henle generates positive potential difference in the lumen, and it is the positive potential difference which then leads to the reabsorption or movement of calcium and magnesium, which are positively charged molecules, across the paracellular pathway, which are controlled by claudin 16 and claudin 19 complex of proteins. Sorry, I'm going down. Okay. Moving on from the thick ascending limb of loop of Henle, the reabsorption of magnesium in the distal convoluted tubule, which is the site of active magnesium reabsorption, is dependent on the adequate functioning of the transporter TRPM6, which is also located on the luminal membrane of the intestinal cells. And this is the transporter which is responsible for the reabsorption of 5 to 10% of filtered magnesium across the luminal membrane of BCT cell into the inside the cell. Once inside the cell, again the magnesium exits either through a sodium magnesium antiporter or through another protein which we just discussed earlier, CNNM4 protein, which is an conserved vertebrate metal transporter on the basolateral membrane of the BCT cell. So in summary, magnesium homeostasis depends on 3 organs: the intestine, which facilitates magnesium uptake; In health, about 30% of magnesium is absorbed across the luminal membrane of the gastrointestinal tract, mainly in the distal jejunum, ileum, and the colon. In cases of magnesium deficiency or decreased intake of magnesium, intestinal uptake can increase to the tune of 70 to 80%. The bone, which is the main magnesium storage system of the body, contributing to 60% of the magnesium stores, and the kidneys, which are responsible for magnesium excretion. Let's move on to some cases associated with magnesium disorders. This is a 15-month boy who presented with primary steroid-resistant nephrotic syndrome, had persistent anasarca for 6 weeks with intermittent vomiting, poor appetite, and intermittent diarrhea because of gut wall edema. He was on adequate dose of steroids and also diuretics to reduce his anasarca. He presented with generalized seizures for 2 days, 6 weeks into the onset of his disease. There was no hypertension, no infection, or no venous sinus thrombosis on the brain MRB. His corrected calcium was 7.2 milligrams per deciliter, magnesium was 1 milligram per deciliter, and phosphorus was low normal. So this was very obvious that this child has got hypomagnesemia with secondary hypocalcemia. And the question is, what is the cause of hypomagnesemia in this 15-month-old child? I think there are multiple factors which contributed to hypomagnesemia in this young infant. The first, the decreased oral intake because of his nephrotic state. His oral intake had reduced for the past 2 months. Decreased GI absorption because of the significant gut wall edema associated with severe hypoproteinemia. The increased GI losses because of diarrhea, again because of gut wall edema, maybe some infection as well. And on top of it, he was prescribed diuretics, which we know is going to increase the magnesium loss in the urine. And I think that's what tipped the balance of his plasma magnesium concentration, and he developed significant hypomagnesemia with seizures. As we know, the roles played by different hormones in regulation of different cations, aldosterone and atyl natriuretic peptide regulate sodium concentration. Susan beautifully explained about the role of antidiuretic hormone or vasopressin in the water homeostasis. We do understand the importance of aldosterone as well as the body potassium stores, which regulates the potassium balance, and not to forget the role played by parathyroid hormone, vitamin D, calcitonin, and bone stores in calcium homeostasis. In contrast, magnesium is treated by the body as an orphan. There are no hormones, unlike the hormones associated with the above cations, that will have a substantial role in regulating urinary magnesium excretion, and bone, the principal reservoir of magnesium, really does not readily exchange with the circulating magnesium. So unlike the remaining 3 cations, magnesium is a bit different and considered to be an orphan cation. Moving on to another case, a 5-year-old girl who presented with polyuria, polydipsia, poor appetite for 2 months, had constipation and occasional vomiting with weight loss. This girl had a weight of 17 kilos. She was well grown with normal blood pressure. Her urine showed a specific gravity of 10.05 with no protein, no sugar. There was euglycemia. Electrolytes showed mild hyponatremia, hypokalemia with normal venous blood gas. Her corrected calcium was 7.4 with phosphorus of 3.2, magnesium of 1.2, and albumin of 2.7. Blood urea was 10 and serum creatinine was 0.5. Urine osmolality was 176 milliosmoles per kilo of water. It is lower than what expected, but it is not very low as we see in children with central diabetes insipidus. We obtained an ultrasound abdomen because of a acute to subacute history, and what that showed was a mass in the upper pole of the right kidney over here. On exploration and nephrectomy and then histopathology, it was confirmed to be a right Wilms tumor. So the question is, what were the reasons why this child had polyuria, polydipsia, hyponatremia, hypokalemia, hypomagnesemia, hypophosphatemia, hypocalcemia. So what is the reason this child presented not in a typical manner as a child with tumor would present, but this child presented in a different manner? And I think this is what it took us about 3 days to put things together. And what we could analyze is that the Wilms tumor resulted in poor appetite because of release of various cytokines and inflammatory markers. This poor intake resulted in decreased intake of both macro and micronutrients, including the various minerals which are required for body's metabolism. Because of this, she had hypokalemia, hypomagnesemia, hypocalcemia, and hypoproteinemia, which was very obvious on the previous slide. The hypomagnesemia potentiated the hypokalemia, and the hypokalemia then caused the secondary diabetes insipidus, as Susan had mentioned, that hypokalemia will interfere with the cyclic AMP and the movement of aquaporin channels onto the luminal membrane of the collecting tubular cells. The secondary diabetes insipidus and polyuria made her thirsty, and that's how she had polydipsia. Because of polydipsia, her stomach used to be filled with water that again further decreased her appetite and then perpetuated the cycle. So what is an important message I would like to share over here is whenever we have a child with hypokalemia, hypomagnesemia, also look at the other electrolytes and the protein level. And when you have a child who has got hypokalemia, hypomagnesemia, hypocalcemia, and hypoproteinemia, what my bosses used to tell us, Professor Selden in UT Southwest, is there are only 2 differential diagnoses over here. One, it's malnutrition in children and chronic alcoholism in adults. So I think when you have this 4 typical constituent findings, please think about chronic malnutrition and find out the cause of chronic malnutrition as your next step for evaluation. Case 3 is an 18-month boy who presents with recurrent seizures since 2 months of age. He was on 4 anti-epileptic agents. He also has developmental delay. Calcium was low. Magnesium was very low at 0.5 milligram per deciliter. There was modest improvement in his blood calcium and magnesium levels with IV replacement on oral magnesium. Magnesium level improving to about 0.9, but that was still not sufficient for him to not have seizures. He continued to have seizures despite a slight increase in his plasma magnesium concentration. So what was the cause of hypomagnesemia and hypocalcemia in this infant who presented at an early age with recurrent seizures and developmental delay? Certainly, obtaining a 24 hours urine magnesium test was difficult. We would have to put in a urinary catheter to collect the urine 24 hours sample. We did a spot urine for fractional excretion of magnesium, and that turned out to be very high in the presence of severe hypomagnesemia. It was 3%. We would have expected it to be less than 1% if the kidneys were conserving magnesium. We did go ahead and obtain his whole exome sequencing, and that confirmed that he was having a homozygous mutation in the transient receptor potential melastatin 6 gene responsible for absorption of magnesium both in the intestines as well as in the apical as well as the luminal membrane of the distal convoluted tubular cells. The treatment over here, what we moved on was to give him chronic therapy with intramuscular magnesium sulfate 3 times in a week, along with oral calcium max as well as magnesium oxide, because giving him only parenteral magnesium sulfate would not have been practically possible. The parents were very, very upset with the diagnosis as well as with the recurrent seizures which the child was suffering for the past 2 years before he came to us. But we had to explain to them the importance of giving him parenteral magnesium to bypass the impaired absorption in the intestines. We targeted a plasma magnesium concentration of around 1.2 to 1.4, and we were successful in raising this plasma magnesium level. With that, the calcium level also improved to about 8 to 8.5. And within 3 months of initiation of this therapy, he was seizure-free. He is now 5 years of age, seizure-free for the past 2.5 years, and able to manage his day-to-day activities with improvement in mental development. He is now on intramuscular magnesium sulfate once in 7 days. So please think about inherited defect in magnesium absorption, either in the intestines or in the renal tubules whenever there is a child with resistant hypomagnesemia. Just to recap, most of the magnesium is absorbed in the distal jejunum, ileum, and colon, 90% through the paracellular pathway and 10% through the active transcellular pathway through the TRP, M6, and 7 transporters. And it is a defect in this transporter which was responsible for the impaired oral magnesium in this boy. Unfortunately, he had a mutation likely in the TRP M6 transporter on the apical membrane of the DCT cell, because his fractional excretion of magnesium was high at 3%. If it was only the intestinal absorption defect, you would have expected the renal tubular function to be intact and the urinary magnesium excretion to be less than 1%. But since his fractional excretion of magnesium was high, we presume that he had a defect in both the transporters in the intestine as well as the distal convoluted tubular cells. One on the intestinal cells and second on the apical membrane of the DCT cells. Moving on to case 4, this is a 5-year girl with Bartter syndrome confirmed to be type 3 due to chloride channel KB transporter defect, diagnosed at 3 months of age. Her initial calcium was 9.2. Magnesium was mildly reduced at 1.6 milligram per deciliter. She was initially managed with oral ibuprofen. Later on, from 2 years of age, we shifted her over to COX-2 inhibitors, etericoxib, which is what we have been using in our children with Bartter syndrome. Along with that, lansoprazole, oral potassium, and oral magnesium supplements. For the past 3 years, she was having recurrent carpopedal spasms requiring IV corrections. There was no diarrhea. Her electrolytes were always acceptable for her. Potassium of 2.5 was quite good for her. Corrected calcium was 7.8, and magnesium, which used to be around 1.6 to 1.7 earlier, had now dropped to 1.1 milligram per deciliter. So the question is, what's the etiology of a worsening hypomagnesemia? Is it just the Bartter syndrome, or are there any other factors responsible for a symptomatic hypomagnesemia? So let's just move on to the physiology at the level of thick ascending limb of loop of Henle. We have the luminal membrane on the left side and the basolateral membrane on the right side. We know that the sodium potassium 2-chloride co-transporter, which is an electroneutral transporter taking sodium, potassium, and 2-chloride ions into the cell, is responsible for about 25 to 30% of sodium chloride reabsorption in the nephron tubular segment. Potassium is secreted back into the lumen to allow the recycling and for the function of the sodium potassium 2-chloride co-transporter. The sodium and chloride which are entering the cell leaves through the sodium potassium ATPase as well as the chloride channel. The positive potential difference generated by the reabsorption of sodium chloride results in the net movement of positively charged ions, mainly the sodium, calcium, and magnesium, across the pericellular pathway into the interstitium and the blood compartment. So this is what happens physiologically. In Bartter syndrome, there are multiple sites where there can be a defect in reabsorption of these ions. Type 1, as we all know, is due to a defect in the sodium potassium 2-chloride co-transporter, the solute carrier gene. Type 2 is due to a mutation in the ROMK gene, the KCNJ gene, resulting in a defect in the renal outer medullary potassium channel. Type 3 is because of a defect in the chloride CIC-KB channel, the kidney B subunit of chloride channel. Type 4 is because of a defect in the Bartin gene, which is a unit of both the chloride channel A as well as chloride channel B, and hence it is resulting in much more profound sodium chloride wasting. Type 5 is because of an activating mutation in the calcium sensing receptor present on the basolateral membrane of the thick ascending limb of loop of Henle. And the type 6, which I have not depicted over here, is because of the MEGET2, which is the melanoma associated antigen 2 gene defect seen mainly in fetal life, and it's usually a transient phenotype of Barter's, and they usually get better by 6 to 8 months. So this particular patient of ours had a defect in the chloride channel KB, resulting in Bartter syndrome type 3. So what was the reason of hypomagnesemia in this child over the past 3 years? This is one of the important reports of hypomagnesemia following prolonged use of proton pump inhibitors. Unfortunately, PPIs have become one of the most widely abused medicine in both adult medicine and to some extent in pediatric practice as well. This was first introduced in the market about 30 years ago, and hypomagnesemia was reported as a side effect of this agent about 15 years after its entry into the market. It has been believed that about 1% of patients on chronic PPI therapy would experience hypomagnesemia, and that's a good percentage of patients who are receiving PPIs. The prime culprit in hypomagnesemia induced by PPIs is an impaired intestinal absorption. We do not know how does this PPI inhibit the TRP M6 transporter, but it is believed that it is because of the inhibition of the active transport of magnesium across the transcellular pathway. So pediatricians and physicians need to be aware of this adverse effect of long-term medication with proton pump inhibitor. And this is what we thought was contributing to her worsening of hypomagnesemia, because she was on lansoprazole along with her COX-2 inhibitor. We discontinued lansoprazole, initiated her on ranitidine, and she has been doing much better over the past 2 years, with magnesium coming back to around 1.6 to 1.8 milligram per deciliter with very infrequent episodes of carpopedal spasm. In fact, the last one she had was almost a year ago. She's certainly on oral magnesium oxide therapy as a replacement for a magnesium losses in the urine as part of a Bartter syndrome. And the final case is a 12 years girl with CKD stage 3 due to hypercalciuric medullary nephrocalcinosis, who was treated with supportive care as well as thiazides for her hypercalciuria. She came with a calcium of 9.2 milligram per deciliter until 15 years, when it was suddenly detected to be 7.2 milligram per deciliter. She was asymptomatic. At this point, her magnesium level was checked and it was found to be 1.2 milligrams per deciliter. And a whole exome sequencing confirmed that she had a homozygous mutation in the claudin 16 gene, confirming hypomagnesiemic hypercalciuric nephrocalcinosis. So my question was, why did this young girl develop hypomagnesemia at such a late age? One, it was a delayed diagnosis. We had not checked the magnesium level earlier, assuming that she had an established CKD with a eGFR of 35 mL per minute, and hence her magnesium would be normal or high. So this was missed by the initial during the initial visits. And the other possibility was that thiazide diuretic therapy was instituted for a hypercalciuria in order to arrest the nephrocalcinosis and slow the progression of chronic kidney disease. And we thought that this could have contributed to her worsening hypomagnesemia. So what happens in hypomagnesiemic hypercalciuric nephrocalcinosis? Again, the defect is in the claudin 16 or claudin 19 proteins, which are responsible for reabsorption of about 50 to 60% of magnesium across the paracellular pathway. When we use thiazide diuretic, we are blocking the sodium chloride co-transporter on the upper membrane of the DCT cell, and inhibition of this transporter has an inhibitory effect on the TRP M6 transporter. How this inhibition downregulates the TRP M6 transporter is not exactly known, but because of downregulation of this transporter, magnesium reabsorption is inhibited, and hence there is increased magnesium loss in the urine, contributing to hypomagnesemia. And finally, friends, prevalence of hypomagnesemia in children admitted to pediatric intensive care unit and its correlation with patient outcome. This is just one slide which I would like to highlight over here, is that we are our intensivists have been taking care of more and more sick children over the past 2 decades. Definitely the management has been more intensified. To some extent, the outcomes have improved. But again, magnesium, as we said, it is an orphan cation in the body. It is almost like an orphan cation for us to think about. We often don't pay attention to magnesium concentration in a sick child. We assume that the child has come acutely and things are going to be okay and fine. But in this study from Karnataka, from Hubli, 344 children admitted in the PICU were prospectively followed for the incidence of hypomagnesemia. And it was surprising that almost a third of this 344 children had hypomagnesemia. This was correlated with various parameters. And what they found was the length of stay in children with hypomagnesemia was definitely longer. 1/3 of patients with hypomagnesemia also had hypocalcemia. 1/3 of these patients with hypomagnesemia also had hypokalemia. And as we know that all these 3 electrolyte disturbances can contribute to cardiac arrhythmias and sudden cardiac arrest. Mortality rate was higher in those with hypomagnesemia, 30%, as compared to those with normomagnesemia. So their conclusion was that patients with hypomagnesemia had increased duration of PICU stay, other associated electrolyte abnormalities, and higher mortality, and hence monitoring of magnesium levels in critically ill patients is absolutely important. So to summarize the etiology of hypomagnesemia on this slide, it could be because of GI factors, decreased intake, malnutrition because of a number of factors. It could be because of decreased GI absorption, as in children with familial hypomagnesemia because of TRPM6 mutation or chronic PPI use. It could be because of increased GI losses, a rare cause, but yes, in children with chronic diarrhea, it can contribute to hypomagnesemia. Or it could be because of increased renal losses, either at the level of proximal tubule, when there is volume expansion, or when children are recovering from ATN. It could be because of a defect in the thick ascending limb of loop of Henle, because of use of loop diuretics, hypercalcemia, Bartter syndrome, and familial hypomagnesemia, hypercalciuric nephrocalcinosis. It could be because of a defect in the distal convoluted tubule, use of thiazide diuretics, use of epidermal growth factor receptor inhibitors, commonly used in adult oncology practice, Gitelman syndrome, familial hypomagnesemia with secondary hypocalcemia, and isolated familial hypomagnesemia. So these are some common causes of hypomagnesemia in children. We should not forget the importance of drugs which can contribute to hypomagnesemia. And these are some of the few drugs which are commonly associated with hypomagnesemia. Cisplatin is the prototype of chemotherapy drug which can cause hypomagnesemia in up to 25%. CNI inhibitors, especially tacrolimus, which we have been using more and more over the past 2 decades. In one study of children post-renal transplant, almost 65% of children with tacrolimus on board had significant hypomagnesemia. Aminoglycosides, besides causing acute tubular injury, can also cause hypomagnesemia. We do know the side effect of amphotericin B on magnesium and also of phoscarnate. So in addition to various inherited and acquired causes, we should always pay attention to the use of drugs which can contribute to hypomagnesemia. So the symptoms and signs of hypomagnesemia are related to dysfunction of neuromuscular system, cardiovascular system, and skeletal system. As mentioned over here, we are all familiar with this, and I will not go into the details of the symptoms over here. And often the symptoms of hypomagnesemia are related to disturbances in other electrolytes, especially potassium and calcium depletion. So how does hypomagnesemia cause hypokalemia? Again, the pathogenesis is not clear, but what has been postulated is that magnesium physiologically inhibits the apical membrane renal automedullary potassium channels in the cortical collecting tubular cells as well as in the thick ascending limb of loop of Henle. So when there is magnesium depletion, the inhibition on this ROMK channels is released, and hence more potassium is secreted. And the other factor is because of decreased activity of sodium potassium ATPase, magnesium being an important component of this ubiquitous enzyme, is required for movement of potassium from extracellular to intracellular compartment, and that is also going to be affected. Hypocalcemia is because of both inhibition of PTH secretion when the magnesium level is low, and also whatever PTH is circulating in the body is not able to act on the osteoclast because of PTH resistance in presence of hypomagnesemia. So how do we approach a child with hypomagnesemia? Well, in most children, it is evident from history. A carefully obtained detailed history is what is required when approaching any child with a problem, specifically with hypomagnesemia. Always check complete urine examination, serum electrolytes, venous blood gas, calcium, phosphorus, albumin, and serum creatinine. If the etiology is not evident based on the above 2 points, we can obtain a 24-hour urine magnesium in a toilet-trained child. If the urinary magnesium concentration is more than 24 milligrams, that is more than 1 millimoles per day, it would suggest renal magnesium wasting. As we said, that kidneys have the capacity of reabsorbing 99.5% of filtered magnesium. The other way to look at the urinary magnesium loss is by calculating the fractional excretion of magnesium in the same way as we calculate FeNA. Only thing is we consider plasma magnesium times 0.7 because that's the free magnesium which is filtered and not the 100% of the plasma magnesium. Again, if this number is more than 2%, it would mean that the kidneys are contributing to the magnesium losses. If it's less than 2%, you can say that kidneys are conserving magnesium. So if it is not evident from the urinary magnesium losses, think about extrarenal losses or reduced intake, often malnutrition. And finally, how do we treat and when do we treat children with hypomagnesemia? The upper half of this table denotes the reference range for magnesium concentrations in the plasma. The lower half denotes the treatment of hypomagnesemia. So when we have magnesium which is less than 1 milligram per deciliter and the child is symptomatic, suddenly we need to give IV magnesium. If the child is asymptomatic and magnesium between 1 and 1.3, we can safely treat him with oral magnesium. If the child is asymptomatic and has a magnesium of 1.3 to 1.8, there is no need for acute management and consider oral supplementation with monitoring. And certainly if the magnesium is more than 1.8, we are dealing with a child who has got normal magnesium concentration. There are different salt preparations which are available in the market. I'm not going to go into the details of this, but we should be aware about the amount of elemental magnesium which is present in each salt, magnesium oxide, magnesium hydroxide, which are the commonly used oral magnesium supplements, magnesium citrate, which we often use in children with renal stone disease, and magnesium sulfate, which is a parenteral preparation used in children with symptomatic severe hypomagnesemia. Some guidelines regarding management of hypomagnesemia. For severe and symptomatic hypomagnesemia, we use IV magnesium sulfate at 20 to 50 milligrams per kilogram per dose, slow IV over 2 to 4 hours, and then every 6 hours as required. It's important to note that we should not give the magnesium sulfate as a bolus, not only because of the risk of side effects, including respiratory muscle weakness, but more importantly, an increase in the plasma magnesium concentration is going to inhibit the reabsorption of magnesium at the level of thick ascending limb of loop of Henle, so that after 3 to 4 hours, the overall plasma magnesium concentration is going to be lower. So rather than giving an acute dose fast, give smaller doses more frequently. If the patient is asymptomatic or has minimal symptoms, it is always best to treat them with oral supplements in the dose of 30 to 60 milligrams per kilo of elemental magnesium per kg per day in 2 to 4 divided dosage. Please remember that diarrhea is the dose-limiting side effect of oral preparations, and hence it is always prudent to use small doses of magnesium supplements frequently. Identify and treat the underlying disease, and be careful when administering magnesium in patients with impaired kidney function. We should give orally as much as possible at usually half the dose and monitor the plasma magnesium levels. And finally, few slides about hypermagnesemia. Fortunately, it is an uncommon problem, but yes, we can see them in children with chronic kidney disease. It is defined as plasma concentration more than 2.4 milligram per deciliter, often seen in children who are having AKI or CKD when magnesium supplements are inadvertently administered, or if there is overzealous or rapid IV administration, even when the renal function is normal. And very rarely it could be because of tumor lysis syndrome, bone metastasis, when there is a sudden release of intracellular ions, including potassium, phosphate, and magnesium into the circulation, which the kidney is not able to get rid of. Clinical features, we are all familiar. It can cause hypotension, paresis, respiratory depression, and certainly it can cause cardiac arrest and coma as well. Acute treatment is to give IV calcium as an antagonist to the magnesium in the plasma. As with treatment of hypercalcemia, forced saline diuresis with high furosemide can be given if the renal function is normal, and certainly if the child has got CKD, prompt institution of hemodialysis would be life-saving. The point I would like to share over here is that the prevention of hypermagnesemia is more important, and hence we should avoid magnesium-containing laxatives, cathartics, enemas, and antacids, as well as supplements in children who have got chronic kidney disease or acute kidney injury. These are some of the commonly available antacids which contain magnesium, like Gelusil, Digene, magnesium carbonate containing antacids. We should be aware and avoid using it in children who have got chronic kidney disease or AKI. Laxatives such as smooth and cramafin, which has magnesium hydroxide, and same way milk of magnesia, which is magnesium hydroxide. These are the preparations which should be avoided in patients who have got chronic kidney disease. So to summarize, magnesium is an important cofactor in a number of enzymatic reactions, including ATP generation. Magnesium deficiency is often an underestimated and ignored metabolic disturbance. Malnutrition, increased GI losses. It should be increased renal losses through diuretics and inherited defect in the thick ascending limb of loop of Fenley and DCT are common causes of hypomagnesemia. The etiology can be identified through thorough history, urinary magnesium excretion test, and now with the availability of genetic studies. Management depends upon the severity and clinical status of hypomagnesemia. Hypermagnesemia is uncommon but can develop in children with AKI or CKD, and hence magnesium-containing antacids and laxatives should be avoided in these children. I would like to stop over here and thank you once again, and hope we remember to take our daily requirement of magnesium through this magnesium-rich foods in our diet. Thank you once again.
So that's a terrific presentation, sir, with the different types of case scenarios where you have explained in detail about the magnesium metabolism. Thank you, sir.
Thank you.
So now we'll go through a few questions. This is to Susan Uthup, madam. This is about a 2-year-old boy with central diabetes insipidus confirmed. We have done water deprivation test and desmopressin test that has confirmed central DI. Here, what is the duration of medication? How many days we have to use? And what is the maximum dose? Whether dose depends upon the weight, age.
It is a congenital central DI proven.
Yes, ma'am.
Yes.
Yeah.
So that means the treatment will have to be lifelong, since the child is not going to be having his this AVP coming. So the tablets that are available, previously we were having the intranasal preparations which are no longer available. Now we have got the tablet form. The tablet strength is 0.1 and 0.2 milligram tablets are available. Usually we will be starting half a tablet 2 times daily, and you can increase to 3 times daily. You can go up to 2 milligram, 1.2 milligram as the total dose. That is 0.4 milligram 3 times will be the maximum dose. That much may not be required usually, but keep monitoring the urine output as well as the serum sodium, so that the titration will have to be done.
And is there any role of intranasal, madam? We have stopped it completely. Only oral we are using. Anywhere we are using intranasal?
Now we are having only oral preparations only. Intranasal is completely stopped. And the oral preparation is actually 20-fold less potent than the intranasal. So we will be using the tablets. It is available as 0.1 and 0.2 milligram tablets are available. And it comes in a small bottle, 100 tablets will be coming. So the parent can procure it and keep on giving it. And the dose can be adjusted based on the sodium and the urine output.
Now we are getting mineral melt, like this one.
Health tablets are available.
Dissolved tablet. Is there any superiority over this tablet, madam? This one? Both are same.
Both are same. Mel's is what is available usually.
Yeah, thank you. Thank you. This is to Sir Mehul Shah, sir. This is about a kid, 1-year-old kid boy with familial hypomagnesemia. And this child has profound hypomagnesemia. Initially, it was 0.8. Initially managed with IV medication. Then we are able to attain around 1.1 mg per dl. Here we have to continue oral. What is the best oral form, sir? Magnesium.
Yes, the best one would be magnesium citrate, but the amount of elemental magnesium which is present in magnesium citrate is lower as compared to in magnesium oxide and magnesium hydroxide. The highest concentration of elemental magnesium is in magnesium oxide. It's about 60%. So about 600 milligrams per 1000 milligrams of the salt. So the best would be magnesium oxide. The only limitation is going to be the diarrhea. So the point is going to be to give small amounts of magnesium oxide frequently. This can be used only in patients who are having a renal magnesium wasting condition. If it is an intestinal absorption defect, then we will have to give a parenteral form of magnesium on a regular basis. So I think that's something which should be important to identify, whether it's just an isolated renal or whether it's an isolated intestinal absorption defect, or it's a combination, and sometimes it may be difficult and it could be a combination of both the defects. So I would say in our country, yeah.
Yes, sir. Yeah, please, sir. Please. Sir.
I think right now what is available in our country is magnesium oxide. And before magnesium oxide was available, we used to use milk of magnesia, which is magnesium hydroxide, little lower concentration of elemental magnesium, but still it worked in a lot of children. But now with magnesium oxide being available, that's something which we are using on a regular basis. Yes.
And so what is the duration, sir, here? Suppose if we're able to reach levels around 1.8 with medication, so we have to use these medicines for lifelong?
Yes.
Are you able to tap? Yeah.
I think, again, like with any inherited defect, this intake is going to be on a long-term basis, probably lifelong, unless if there has been some spontaneous maturation, which sometimes we do see in some of our inherited disorders. And if there is some alternative channels, or if there is a maturation of some of the defective channels, and there can be some increased absorption. So you may be able to titrate down the dose, but my feeling is that most children are going to require it for a longer and lifelong period. But we have been surprised in some of our children. We have been surprised. Yes.
Thank you. Thank you. This is to Susan Uthup, madam. This is about a 6-month-old boy with birth weight of 3 kg. Right now 6 months, but weight is only 4 kgs, has polyuria and has hypernatremia, renal functions are normal, sodium is 170. We have done urine osmolality. Urine osmolality is only 110. Serum osmolality is 340. So 6-month-old boy, madam, whether this kid requires medication, and that is one thing, and he requires further evaluation like water deprivation test and desmopressin or not.
See, 6 months with a serum osmolality that is 340 and the urine is 110.
110, yeah.
Yeah, definitely it's already the diagnosis is obvious, and in children who are below in infancy, it is a contraindication for water deprivation. And then this serum osmolality, which is already more than 300, is again a contraindication. And so this baby, we will be going ahead with the MRI brain and then the genetic study. And then depending on the diagnosis, we have to proceed. First of all, you have to correct the hypernatremia by giving free water, and you have to stabilize the baby, and then proceed with the investigation and give the drugs as per the final diagnosis.
Yeah. This is to Mehul Shah, sir.
Yes.
This is about a kid with FHHNC, sir. The child has profound hypomagnesemia. And initially, the magnesium is very less, 0.6. So we have started combination of medication. And the child during a therapy developed renal failure. Urea and creatinine has gone up. Creatinine has reached 2.5. So, but again, the magnesium is in between like 1.2 and 1.3 with oral medication. But slowly creatinine is going up. So what is the optimum dose of magnesium here, sir?
Sorry, I missed Satya Prasad. What is the primary condition?
FHHC, sir. Familial hypomagnesemia, hypercalciuria, nephrocalcinosis.
Yes, right.
We started medication. Initially, we have given IV because of a profound hypomagnesemia. Later on, we have changed it to oral form, magnesium oxide.
Right.
But progressed to renal failure slowly. Creatinine initially it was 0.6. Slowly it has gone up to 2.5, but still has hypomagnesemia.
Yes.
So, yeah. Is there any can we increase the dose of magnesium, or whether this leads to again progressive renal damage?
No. So I think one point is that certainly the progressive chronic kidney disease in a patient with familial hypomagnesiemic hypercalciuric nephrocalcinosis will make it difficult to titrate the magnesium dose. But as long as the patient is asymptomatic from the hypomagnesemia, the plasma calcium level is maintained in the reference range, I think we can just continue to give oral magnesium until the magnesium level starts increasing to above 1.7, 1.8, because we don't want hypermagnesemia to develop in a patient who has got progressive chronic kidney disease. So I would suggest to continue with the oral magnesium, titrating to the level of around 1.3 to 1.5. We are not going to expect a magnesium level to be completely normal, though in patients with CKD, yes, we would expect it to normalize because of impaired excretion in the urine. But I would suggest that this patients would be continued on oral magnesium, and only thing is more frequent monitoring of magnesium would be required. In my patient, which I just described, which I initially missed to check the magnesium, this child is now having a GFR of around 20 mL per minute, and she's still getting about 1200 milligrams of magnesium oxide and about 500 milligrams of calcium-X per day to maintain a magnesium at around 1.3, and she's doing fine right now. Yes.
Great. Okay. And regarding same thing, FHHNC, is it recurrent after kidney transplant?
No, it is not recurrent, because the new kidney will be having its own transporters in the thick ascending limb of loop of Fenley, so it is not going to recur in the new kidney. Absolutely not.
Sure. Thank you, sir. Thank you. This is to madam. If we have done a child with diabetes insipidus, we have done water deprivation test, and we have done desmopressin test also, vasopressin test also, but results are not conclusive. What is the best mode of combination medication here?
Yeah, the thing is that you will be having maybe a partial central or a partial nephrogenic. So definitely desmopressin you can give a trial because there was a partial response, and combine with the other drugs as indicated to maintain a motor balance. See, it is actually nothing is hard and fast here. When the tests are actually inconclusive and you are nowhere, you have to use the medications that are currently available, combination. At the same time, most important is allow the child to drink enough water. A free access to water is most important. I am following a child who is, I was seeing that boy from 3 years onwards, and now he's 12 years. He's passing almost 8 to 10 liters of urine a day and drinking also that much. And he's on desmopressin, he's on thiazide, hydrochlorothiazide, then amiloride was there when it was available, and indomethacin. Still, his urine output is remaining so high, and the water intake is also so high, but growing well. And so it is a via media way of going. And his sodium is always around 140, 138 to 142, 143. So you have to just adjust with that. You have to maintain it around 140, and the urine output, you will have to allow the child to drink enough water and give a high calorie diet with less salt and less protein.
Great. This is to sir. Is there any correlation between hypomagnesemia and supraventricular tachycardia in children?
It's a good question. I do know that hypomagnesemia is associated with cardiac arrhythmias, like Torses deplans. It can cause ventricular arrhythmias, specifically whether SVT is a feature of hypomagnesemia. I'm not aware. It can definitely cause ventricular arrhythmias. Tachycardia has been known, but tachycardia to the extent it is due to SVT, I'm not aware. Definitely there are studies of hypomagnesemia causing cardiac arrest in patients who have had recent myocardial infarction and hypomagnesemia. So certainly it is not good for the heart rhythm, but specifically for SVT, I'm not aware. I'll need to check that.
Thank you, sir. And another question to Sir Ravi.
Yeah. Unless if Susan would like to answer that. Susan, I'm
No.
not sure, Susan. Are you aware whether hypomagnesemia can contribute to SVT?
No, I'm not aware. I'm not aware.
Right.
This is to Sir. Last question. Child with the profound hypomagnesemia, we started oral magnesium, sir. We have reached almost 80 mg per kg per day. Still magnesium levels are low only. Is there any drug which increases the absorption of magnesium? Can we use orally, which increases magnesium absorption?
So I think having understood the physiology of absorption of magnesium across the intestinal cells, I think most of it is passive and partly it is active through the transcellular TRP, M6 and M7 transporters. I'm not sure if there are any drugs which can stimulate the transporters to increase the reabsorption, increase the absorption of magnesium. The only known factor which is there to increase the absorption of magnesium is actually decreased intake of magnesium and hypomagnesemia itself. So I think already the system is revved up, and I am not aware if any drugs are there as of now to increase the absorption. I'm not aware.
Thank you, sir. Thank you, madam. So that's it. These are the questions we have.
One question
1 minute.
from a participant, whether copeptin levels can be done and what is the consensus to perform the test?
Actually, copeptin as of now is a research molecule, and it is done by ELISA using ELISA kits. It is not freely available in labs and expensive. You can see. The thing is that giving copeptin, you will be checking the copeptin. The concept came because analyzing AVP, even with radioimmunoassay, because the half-life is so short, it was not reliable. So this research has actually led to utilizing this copeptin molecule, which is actually a surrogate indicator, as I have already said, and it is not widely available as for the clinical use, and it is quite expensive. The kit is also quite expensive, I presume.
Thank you, ma'am. I think sir has already answered the question. For children with F, HH, and C, can parents be donors for renal transplant for their children?
Yes, I think they can be donors, because we know that most of the genetic tubular disorders are autosomal recessive, where the children would be receiving a copy, a defective copy each from each parent, and the parents are going to be asymptomatic. So they can be prospective donors for their child with ESRD. There should not be any contraindication.
Thanks, sir. I think we are done with the questions. Thank you so much, Mehul sir. Thank you so much, Susan madam, making the complex, very, very complex topic of diabetes insipidus and magnesium disorders very simple.
Thank you.
Namalva sir, you have anything to add on, sir? Sir, you have to unmute, sir. You're muted.
I have nothing to add except to say I'm so happy to hear both of them speaking so professional, so academically. It has been a great lesson for me. And I fully agree with Dr. Satya Prasad. It is a terrific presentation. Congratulations to both of them. You have chosen the right speakers for the right subject. You know. Congrats with you also, Kalevani.
Thank you, sir. Next, we'll go on to the polling session. It is only for the fellows and trainees. Mehul sir, Susan madam, if you want to stay back, it's fine.
Thank you so much. Thank
Thank
you.
you so much, sir.
Thank you, sir.
Satya
Thank you,
Prasad,
madam.
sir,
Thank
thank you
you.
so much for the
Thank you.
moderation. Thank you, Susan,
Thank
madam.
you. Thank you.
We'll next move on to the polling session and the instruction of the polling session. So participants are requested to enter their proper email IDs for future communication. And we have totally 10 questions and it's mandatory to answer all the 10 questions to proceed with the submission. And we'll have 3 star questions in each session. And it's meant only for in case of tie. And we'll take the cumulative score of all 6 polling sessions to select the winners. And so we'll move on to the polling session now. Time starts now. We have 5 more minutes. We are left with 2 more minutes. Last 1 minute left. The poll ends now. Thank you so much, Susan, ma'am.
Thank you, Kalaivani.
Thank you, ma'am. I think you had the very complex questions, ma'am. It's like a medal questions.
Don't disclose it like this to everybody.
Thank you so much, ma'am. It
You're
was really
welcome.
a wonderful presentation, ma'am. You had the slides very crisp and clear. It was really a
Thank you.
complex topic, but you made it really simple, ma'am.
You always give me such topics only. That is my. You
We need
find
to
out.
learn from you, ma'am. It should be a learning experience for me.
Thank you.
Thank you so much, ma'am.
Thank you. Okay, so shall I leave now?
Yeah,
Okay.
yes, ma'am. Sure, ma'am.
Okay.
Thank you
Okay.
so
Bye.
much.
Bye. Then.
Bye-bye, ma'am.
Thank
Thank
you.
you so
Thank
much,
you.
ma'am.
Thank you.